All right, hypotension shock. The only thing that's changed to remember, we took dopamine out of everything except for cardiogenic shock. Honestly, there is no good drug for cardiogenic shock, so dopamine's probably our best bet. So we will keep dopamine in for our cardiogenic shock. We will also keep dopamine in for pediatrics in the rare circumstance that you need a vasopressor in pediatrics. And then once you've given 2 doses of your push dose pressor, so you've given, for what it depends on where they are on the spectrum, but if they're hypovolemic, or if they're distributive, or even if they're obstructive from a tension pneumothorax or something like that, so those folks need fluid. So we're going to give them fluid. We can give them push dose pressors, and if you've given 2 push dose pressors, then you can go ahead and start a dopamine drip if you want to, but you would continue to give push dose pressors to get their blood pressure up to 90 or get their perfusion better. But for the hypovolemic, we're going to give fluids like we normally do, and then our push dose pressors, which I've got on the back. So TXA, we don't have TXA yet, do we? Not yet, but we were working on getting it. So in North Carolina, TXA's got approved for pre-hospital. It's basically, I know we've gone over TXA a little bit in the past, but TXA basically is a clot stabilizer. So in trauma, the things that kill trauma patients the most, it's the trauma triad of death. It's cold, acidotic, and bleeding. So bleeding, cold, and acidotic. Those are the 3 things that kill trauma patients. So we want to stop bleeding. We want to give back fluids to support the blood pressure. And then for here, we would give push dose pressors. And then if you've got to this point, this is absolutely the candidate for TXA. So for TXA, it's that person that's hypovolemic or you suspect may have internal bleeding. Internal bleeding, it doesn't work so much for external bleeding, should have pressure points. That pressure are tourniquets. So external bleeding, we ought to be able to stop. If you suspect somebody's got internal bleeding, especially if they are multi-system trauma and they're hypotensive, don't think too hard about this. Just give them TXA. So it's 1 gram over 10 minutes, and we're still trying to exactly figure out how we're going to bolus that. Probably the easiest way is to just put it in a 10 cc syringe and give 1 cc every minute over 10 minutes. But TXA only if we're going to Baptist, okay? This is the only time in protocols where you do a little something different going to each hospital. But TXA is given it, you can give it at Forsyth, but I don't know that they would be using TXA for trauma at Forsyth. I mean, if you're to the point where you think somebody needs TXA, then trauma center. So TXA, trauma center, multi-system trauma, hypotensive, you suspect that they've got internal bleeding that we can't see. Blood pressure less than 90, heart rate greater than 110. Those are some of the other hard stops for TXA. But if you suspect it, give it. There's really no downside to giving TXA. TXA has been on the market for years. You can buy it in Europe over the counter, PO, not IV. It's been used for years in Europe for dysfunctional uterine bleeding. I've given it a few times for folks who go to the dentist and get all of their teeth pulled and then show up in the emergency room at 3 a.m. because they're bleeding. So it works great for that. We don't give it for that, but I'm saying TXA has been around for a long time. This is not really a new medicine. It's just new to us. But this thing's been well studied. There's been several trials that show improved outcome, and honestly, you only need to treat about 7 patients for 1 good outcome. So aspirin, 4 patients for 1 good outcome. TXA, 7. So these are pretty equivalent therapies and not very expensive. So TXA is the new thing in hypovolemia. Cardiogenic shock, nothing changed. We would just do dopamine as our vasopressor. Distributive shock, which would be anaphylaxis. So here, if you've got distributive shock anaphylaxis, your push dose pressor is here. So you'd be given fluids, and you could give epinephrine. Epinephrine would be your preferred choice. I know phenylephrine in the box, but if you think somebody has an allergic reaction, it's epinephrine is the main choice. And then obstructive, it's a chest decompression, obviously, is going to be our main thing. Or if we think they've got cardiac tamponade, then it's fluids, and you could do push dose pressors there. So basically, push dose pressors is going to replace dopamine, with the exception of cardiogenic shock, pediatrics, and then if you've given 2 or more push dose pressors, then you can go ahead and start dopamine. Now for us, our transport times are just, I would say we're probably not going to need dopamine for the most part. You just keep giving push dose pressors. I like push dose pressors much better. Anytime we can get away from a drip, it's better. All right, any questions about that? All right, cool. So not the only thing I added back here is the TXA. So systolic blood pressure less than 90, heart rate greater than 110. You suspect hemorrhage, shock. You go into the trauma center. Push dose vasopressor epinephrine mix is here, and it's just like it's exactly what we've talked about. So it's exactly the same. Kept the epinephrine drip over there, but honestly, we really don't need epinephrine drip because we can give push dose pressor. So basically, a push dose pressor is that. You just don't use it in a drip. You just give it every 2 to 3 minutes. Right. Multiple trauma, nothing changed here with the exception of TXA. So TXA is there, and cefazolin, so ANSEF. So if you've got somebody with an open fracture, give ANSEF. So we'll talk more about that once we get it. So we don't have it just yet, and we can do some on-shift training with. So ANSEF, Keflex. So lots of folks are probably taking Keflex. Keflex is the PO form of ANSEF, is the IV form. It's 500. It's 1 gram. Excuse me, 1 gram IVIO. If there's anybody that has an open fracture. So, and basically, an open fracture is something that looks broke, and if it's got a scratch and bleeding, it's open. It might be that big. It might be that big. If you got a deformed extremity and they got a lac that big, that's still considered an open fracture. I know that sounds crazy, but I would go ahead and give the ANSEF. Folks who get ANSEF within 60 minutes of an open fracture have much better outcome, better operative outcome, less infection. And you would give ANSEF whether you're going to Forsyth, Baptist, Rowan, doesn't matter, because that is a hospital metrics that everybody is under. So there's you can give ANSEF no matter where you're going. Only caveat, if you're giving TXA, they ought to be going to a trauma center. So if you think somebody's bad enough they need TXA, they should go to a trauma center. All right, any questions? Pretty straightforward. Open fracture, ANSEF. Yes, sir. Yep. No, because MedCenter Air's been doing TXA for about 2 years. Yeah, that's going to be they were the first in the state to start using TXA. Yeah, so MedCenter Air, no issues. Now, if you get wing, I can't imagine you got a Roanoke or something like that, but if you did, I would just, you give what you've given, hand them the syringe and say, this is the rest of the TXA, we give this when we're going to a trauma center. So, and I just leave it up to them to give the rest. Now, when you do that, make sure that you let somebody know that you've given TXA, because then they need another gram over 8 hours once they get to the hospital. So we need to make it clear that they got TXA. It'll be a year from now, it'll be a lot of bumps when we get started. A year from now, it'll be normal practice. So it'll take a little while for everybody to get used to it. But the hospital is now set up to administer TXA to start that second dose in the emergency room for the next 8 hours through the hospital. So it's 2 doses. We're only going to give the first. And the reason we're giving it is because the studies have shown that if you give it within 3 hours, you get the biggest benefit. But if you give it within 1 hour of injury, you get the maximal benefit. So it just makes sense to give it, to put it pre-hospital. You're going to be able to get it faster than anybody else. Those studies have, when it's given in less than 1 hour, the best outcomes. I'd give it. If you think the bone's been violated, I'd give, especially a chainsaw. If you think you're down the bone, if you see tendons, and honestly, it may not be that much bone involvement. It may have just nicked the periosteum, but yeah. So absolutely, and unless they tell you, if they tell you that they are allergic to penicillin, you can still give ANSEF. There's a less than a 2% chance that they'll have a reaction to ANSEF, even if they're allergic to penicillin, because everybody in the free world says they're allergic to penicillin. If they tell you they're allergic to Keflex or ANSEF, then don't give it. But unless they tell you that, give it, because the chance that they're going to be actually allergic to it is really, really low. And we're not going to be giving that much ANSEF anyway. So I want us to get a little bit more used to giving antibiotics, because I want to eventually start moving into a little sepsis. I don't think we don't see that many open fractures. So. Car accident, stuff like that we may, but you're not going to see that. But yeah, chainsaw accident where you think it's got down to where you're seeing tendons and stuff, yeah, absolutely, I would give the ANSEF. There's nothing over here other than just, nothing changed back here other than we just added open fracture or amputation. Then give, obviously, if you've amputated something, that would be an open fracture. Pediatric pain control, the only thing we added was in fentanyl. So, I mean, that's it. Everything else is exactly the same. We just added that you can give it intranasal. Pediatric allergic reaction, it's exactly the same as the adult. There's basically no change. The only thing that really changed was the auto-injector was removed. And remember, 30 is kind of the magic number. If you're over 30 kilograms, then you give the adult dose of epinephrine. If you're under 30 kilograms, then give the 0.15. And that's basically just the EpiPen Junior, sorry, I lost my train of thought. So 0.5 is basically would be an EpiPen, and 0.15 would be the EpiPen Junior. So easy numbers to remember. Less than 30, give the 0.15. Over 30, give the adult dose. Pediatric hypotensive shock protocol. This didn't change at all, but for some reason we realized that dopamine had gotten left off this. I don't know how that fell off, but so now we've just added dopamine to all the things. So that's something that we would have done anyway, but for some reason it just was not on the protocols. Pediatric seizure, the only thing that got added was intranasal Versed. That's it. We just added IN to the protocol. Otherwise, it's all the same. But remember, studies have shown that IV Ativan and IM Versed are almost equivalent. So but there's also been some studies that showed that intranasal Versed was almost equivalent to IM Versed. So honestly, it doesn't really matter which one you give. If you don't have an IV and you don't want to put in an IO, IM or intranasal is absolutely acceptable. Because they're both about the same and they're almost the equivalent of IV Ativan. So we just added that as an additional avenue. Remember, intranasal stuff, put it in the nose and point it to the ear because you want it to fill the turbinates. This is on the outside is where the medicine's going to get picked up. So go in and then point to the ear where it's going to shower the turbinates, and then just kind of pinch the nose a little bit for a minute or so to increase the absorption of that. That's really the only caveats to intranasal. But either way, you can give it either way. IM, though, is a very effective option. Absolutely. Dude, hang on a second. Well, I was going to show you right here. Well, I've got a table on the back that you can refer to. So 5 milligrams in 1 cc, and you've got 2, 4, 6, 8, 10, 12. Your kilograms there rounded off to even, and it tells you the dose, but also tells you the volume that you can infuse. So. Right, it's 5 milligrams in. Right. Correct. Right. Yes, this is 5 milligrams in 1 cc. Yeah, 1 cc would be better. Now, having said that though, I mean, estimates are certainly okay when a kid's seizing. So, giving it your best dose is certainly fine. And I'll tell you that when it comes to these doses here, I cannot remember them, and I have to look them up every time. So I would just whatever you carry as your memory jog. Those dosages are only important when we're doing oral boards because I can't remember them either. So and I have to look them up. So if I'm treating a kid, I look up everything before I give them anything. So even if I'm standing at the bedside and they're having a seizure, I mean, if it's a big kid, no big deal, you give them an adult dose. But if it's a small kid where you're really trying to calculate dose, I'm going to pull up and look at what I'm giving them because I do not trust my memory. And that's not the time to trust your memory anyway when you got a sick kid. So I told you guys, Pediastat is a great app to put on your phone. Pedistat. It's about, I don't know, $2 for Apple and maybe $4 for Android. Or actually, last time I said that, I think it went up. It might be about $6 or $7. But that to me is like the best app because you pull it up and it gives you Broslow tape, age, or weight, and then it's in a category to tell you everything you need to know. So you can click on medicines, you can click on equipment, and it gives you based on if you put an age in or if you put a weight in, everything is now already pre-calculated for you. So, and it's all based basically off the Broslow tape. So to me, that's probably the most spent $7 that I spend at work when I work in peds because I look at that thing about 2 to 3 times every 8 hours. Because and I cannot remember all those dosages, and I don't want to trust myself that I think I've remembered them. I just pull them up and look at them every time. The other thing you can do is like you've got a kid. I always tell you guys, remind you that. So when we don't transport a lot of kids, but when you do transport a kid, when they're otherwise doing okay, that's the time to mentally go through stuff that you would do if they were not doing okay. So look up drug dosages. Say if they're 22 kilograms, look up how much epi would I give them, how much atropine would I give them, how much Versed would I give them. Those are great things. And I'll tell you, even in the hospital, if I got a kid that looks kind of sick and I think I may have to do something later, I will look up a couple of drug doses and I will write them on the sheet on the head of their bed. So that if anything happens, I've got them right there at my fingertip and know exactly what to give them. So it's a good exercise to go through for the 20, 30-minute ride to run through calculating those drug dosages. But Pediastat, I would highly recommend. It's definitely worth a few bucks to have that on your phone. I use it every day. It would be. I mean, you're going to be much more accurate. Right. Yeah. Yep. So 1 cc per nostril. That's about as much as a nose is going to take. So regardless of the dose, it's the volume that's more. So about 1 cc per nose, per nair. Hope nobody has 2 noses. That would be bad. So each nair. All right, the rest of these are really quick. Hyperthermia, remember we went over this. I know we don't have to worry too much about hyperthermia right now. The only thing that got added is when you've got heat stroke, our target temp's 102.5 degrees Fahrenheit. We'll talk more about that at the end of the spring. Hypothermia, though, is on the radar now. And let's see. I don't think anything necessary. Let's see. What did change? What changed? Oh, I know what changed. The only thing that changed is in cardiac arrest, the intervals that you give drugs should be increased. We had the intervals should be reduced. So, but basically under 82 degrees, most of the drugs are not going to work, and there's no reason. You don't want to give them every 5 minutes. So if somebody's in cardiac arrest, say their body temp's 80 degrees and they're in cardiac arrest and you're resuscitating them. You would not want to give epi every 5 minutes because the drugs aren't very effective. It doesn't circulate very well, and then when they get warmer and we do resuscitate them, they'll have 10 milligrams of epinephrine circulating around ready to bing off the kidneys. So you just give them at little increased intervals. But that was it. That was the only thing that changed for that protocol. But so for this time of the year, though, just be very aware of the elderly are really prone to hypothermia, even if they're in a house. That's where we tend to see more people what we call urban hypothermia than we do wilderness hypothermia. The guys out on the backside with in the snow hunting or something like that, it's pretty easy to recognize hypothermia. But the 78-year-old living in a house that seems okay when you walk in, but has been living with 60-degree temperatures for a few days on a bunch of medications, that's the person that's really at risk of hypothermia. That and the alcoholics, chronic alcoholics, all those folks are at risk of hypothermia. So just have a high degree of suspicion for those folks. And remember that the first symptom, so you've got these numbers up there, 90 to 95 degrees is mild, moderate's 82 to 90, and under 82 is severe. But it's better to think of it in symptoms. So the first symptoms of hypothermia is you get a little bit confused, you're a little slow to react, your dexterity is a little bit off, you can't do things as normally as you could, like writing or doing a puzzle, something like that. So a little subtle confusion that's new. This time of year, think about hypothermia because it actually may be prevalent. And then Honestly, hypothermia acts a lot like intoxication. A little bit of confusion, a little bit of stumbling gait at first, more progressive confusion, more stumbling gait, and then they go comatose. So it really kind of follows like alcohol. So just kind of keep that on your differential that somebody could be hypothermic. Very important, because hospitals never going to figure that out, because they're not in the house. They didn't see that. And if you really suspect hypothermia, just mention it, that you're a little worried that they lived in a cold environment, and that you might be worried about that. So just keep a high degree of suspicion for hypothermia. And remember, carbon monoxide poisoning, the most common symptoms are nausea, vomiting, and diarrhea. So, but that's almost the most common symptoms of every other crud that we get in the wintertime. But folks, when you've got somebody that's got weird symptoms, or just sick, headache, not feeling good, kind of confused, certainly want to keep stroke in mind, but ask if you've got gas appliances, oil appliances, are they running that kerosene heater? Keep a high degree of suspicion for carbon monoxide poisoning, because many times by the time you get them to the hospital, they'll be fine because they've been out in the ambient air, maybe you put oxygen on them, and they've actually gotten better. Now, especially if there's more than one person that's there